Welcome to the first virtual NCCN Policy Summit, Accelerating Advances in Cancer Care Research, a look back at the 21st Century Cures Act in 2020. My name is Robert Carlson, and I am the CEO of the National Comprehensive Cancer Network. NCCN is a not-for-profit alliance of 30 leading academic cancer centers dedicated to improving and facilitating quality, effective, efficient, and accessible cancer care. Next slide, please, Mark. NCCN appreciates and recognizes the supporters and sponsors of this summit. Without this support, the summit simply would not be possible. We would also like to thank those of you who donated to the NCCN Foundation as part of your registration. The NCCN Foundation is working to empower people living with cancer and to advance oncology innovation. If we'd like to learn more or make a donation, please visit nccn.org/patients/foundation. Next slide, please, Mark. Today's program will focus on the landmark 21st Century Cures Act by analyzing the successes of the legislation and by discussing barriers to implementation. We will also focus on the future of patient-centric cancer care and medical innovation. This last March, NCCN hosted a working group to discuss many of these issues, and the program will begin with the working group policy recommendations. We will then host a fireside chat with Amy Abernethy to discuss her innovative work at the FDA. Dr. Don Rucker will then provide a keynote address on health information technology and patient-centric cancer care. The program will continue with a panel discussion on the effect of the 21st Century Cures Act on oncology. We will end the day in conversation with Congresswoman DeGette and Congressman Upton to discuss the creation of the Cures Act and future legislation. Clifford Goodman, Senior Vice President at the Lewin Group, will moderate today's program. Dr. Goodman has over 30 years of experience working in healthcare and is a nationally recognized health issues moderator and panel facilitator. At this time, allow me to introduce the NCCN Working Group co-chairs, Dr. Ron Walters, Chair of the NCCN Board of Directors and Associate Head of the Institute for Cancer Care Innovation at the University of Texas MD Anderson Cancer Center, and Dr. Jeff Allen, CEO and President of Friends of Cancer Research. I would also like to welcome Lee Gallo, a Global Policy and Advocacy Fellow at NCCN. Lee coordinated today's summit and corresponding working group, and she will begin by providing background information on the goals and processes of the working group. We look forward to an active conversation today and welcome your questions and engagement throughout the program. And with this, I'll turn it over to Lee.
Thank you, Dr. Carlson. Good afternoon, everyone, and thank you again for joining the NCCN Policy Summit on the 21st Century Cures Act. In conjunction with this summit, NCCN hosted a working group on March 5th with a diverse group of stakeholders to thoughtfully discuss perspectives related to the impact of the Cures Act on patient access to high-quality cancer care. Next slide, please. I'd like to begin by thanking our co-chairs, Dr. Ron Walters and Dr. Jeff Allen, for their commitment to this project. Their expertise has been invaluable, and without their guidance, today's summit would not be possible. In just a minute, they will present the 7 policy recommendations created at the working group. Next slide, please. I'd also like to take a moment to thank all of those who participated in the working group. Each member brought a unique perspective, and I am personally extremely grateful for their time and guidance. 4 of our members will be speaking on a panel later this afternoon. Next slide, please. To begin, I'd like to provide a brief background on the 21st Cures Act. After bipartisan support and collaboration, President Obama signed the 21st Century Cures Act into law on December 13, 2016, providing robust funding for cancer research, precision medicine, mental health illnesses, and the opioid epidemic. The law aimed to advance new therapies and promote medical innovation. It also outlined requirements for future regulations. Next slide, please. On March 5th, the working group set out to meet the stated goals of analyzing the current issues in cancer care related to the implementation and impact of the 21st Century Cures Act to date, and of developing recommendations for short-term policy strategies to address identified gaps and opportunities related to cancer care research, health information technology, and other related topics. The process for meeting these goals included analyzing the legislation and its intended impact on cancer care, assessing how the Cures Act has been implemented to date, discussing the legislation's impact on oncology stakeholders since enactment, and identifying the remaining gaps and challenges as experienced by diverse stakeholders. The working group members specifically discussed the provisions related to the FDA, including clinical trials and real-world evidence, and provisions related to health information technology and patient data. The groups discussed the successes, barriers, opportunities for improvement, and next steps of presented topics. At the end of the day, the group created policy recommendations. Again, I'd like to introduce Dr. Allen and Dr. Walters and thank them for their dedication to ensuring the future of high-quality cancer care. Dr. Allen and Dr. Walters will discuss our 7 policy recommendations in detail now. Thank you.
Go ahead, Jeff, and then you go first, then I'll go second, and then we'll go back to the first recommendation. How's that?
Sounds good. Sounds good. Well, let me first, at least before we jump into the recommendations from the group, I certainly want to thank Lee Gallo for her just terrific leadership and shepherding this group together, to Alyssa Schatz for her help, and the NCCN leadership for taking on this project. As I think you'll hear throughout the day, it's very timely, with great opportunities for us to be able to explore avenues to move forward with these recommendations. So I commend the NCCN leadership for taking this on, and hopefully we can collectively move many of these recommendations forward. But to jump in with the first couple of recommendations, as you saw from the list of participants, who I also want to express my gratitude for their ongoing discussions and really just a robust day in order to get us to the point of being able to consolidate around these initial recommendations. But first and foremost, we thought it was extremely important for us to collectively leverage our voices around the funding that was contained in the 21st Century Cures Act. As Lee noted in her introduction, a substantial amount of funding was provided to various NIH programs, which included about $1.8 billion toward the Cancer Moonshot over a 7-year period. And as time has passed by since the passage of the Act, the funding has peaked during 2019 at its maximum $400 million level and has continued to then begin to wind down over time, as was laid out in the legislation. The winding down of this funding, of course, comes at a time in cancer research where so much is continuing to happen. While many of us were watching and participating in some of the annual congresses that the cancer community gravitates toward in the spring, while we weren't able to be there in person, we certainly saw the continued advancement and really exciting findings. And without the continued commitment to this funding at any time where it becomes unpredictable, unsustained, or is not as robust as it needs to be to support this, ongoing clinical trials and research associated with the new compounds to lead to clinical trials will begin to taper off. So our hope is that as we think about avenues to move forward, that we can come back to a robust and sustained and predictable funding stream. Next slide, please. The second stream is recognizing that in addition to the NIH funding, there was also substantial funding that was provided to the FDA in order to support various scientific activities and new programs. So the same in terms of funding for the FDA is important as is with the NIH. In addition to that, some of the programs that were established in the 21st Century Cures Act have really helped take new innovative steps toward the development and regulation of new products. These include things like establishing the Oncology Center of Excellence at FDA, which the goal of this program was to aggregate cancer-related activities across the different medical product centers at FDA. For example, things like, in addition to typical drug development, which is handled by the Center for Drug Evaluation and Research, the importance of making sure that there's a consolidated and unified approach to different medical products that are now becoming regular components of cancer care. such as diagnostic testing, which is approved in the device center, through the device center of FDA, as well as things like cell and gene therapies, which are approved through the biologics divisions of FDA. In addition to some structural approaches, the 21st Century Cures Act also created new programs, like the Regenerative Medicine Advanced Therapy Designation, which was in large part modeled off of the successes seen through the Breakthrough Therapy Designation to create an expedited avenue for particularly innovative products in order to receive the active involvement from the FDA in order to maximize interaction and really expedite some of the most promising therapies to move forward. I think these programs have truly been success. And as the group thought about how one could build upon this into the future, we thought it was very important to think about ways that the interagency collaboration and communication that has been seen to enhance oncology products could stretch even beyond that from FDA. So we discussed things like looking at ways in which, in terms of a potential next iteration of 21st Century Cures, how to extend that innovative product development into the coverage and reimbursement space, for example. So one area that we talked about was ways that things that the FDA processes, those expedited programs that I mentioned, could be extended to maybe trigger similar processes through payment agencies like CMS in order to make sure there isn't a gap between FDA approval and ultimate patient access and payment for these products. Oftentimes they are the most innovative, so they require new steps such as modifications in coding or different approaches to payment policy that having earlier interactions from FDA leading into CMS processes could be quite beneficial. So you could imagine a scenario where a product receives a breakthrough therapy designation, for example, from the FDA, and while that is still an ongoing process of evaluation and conducting the pivotal trials that may be needed for FDA approval, at that point in time, that could also spark a series of different process modifications to expedite and prime the pump, so to speak, so that these innovative products have a clear path forward through not just the regulatory apparatus, but also the payment apparatus. Next slide.
Okay. This is Ron. As you can tell, and the theme of this is that we really do appreciate the work that regulators, people who write bills, the governmental agencies have done so far. Theme is, and we should not stray from that, that there is so much more to do, and we support doing more even than has already been done. I also would like to thank the participants on the webinar, and of course the wonderful staff at NCCN, the sponsors, the technical support, Mark, and the work group participants especially. We had a fabulous work group made up of a very broad base of people. So as you can kind of start to get a flavor for, we had two work groups. One dealt with the research side of things, and the other one did with the data and IT side of things. So the third recommendation leads into to acknowledge again what has been accomplished and what's has been enhanced for patients being a regular part of their care, but also especially the real world data. A key thing, of course, that happens after clinical trials is real world data starts getting collected. And while there have been many mechanisms established for collecting those, including telephone calls and surveys, et cetera, there is still much to be accomplished in the collection of real world data, especially regarding intermediate term and long-term patient-reported outcomes. That needs to be enhanced so that diverse population groups are represented that the electronic world it spreads to everyone with regards to collecting this data. We have a tremendous amount of real world data that is potentially available. There have been groups established to try to do that on a volunteer basis. And of course, a lot of the discussion revolved around privacy laws in relationship to this endeavor. Nonetheless, all attention should be continued by the Office of National Coordinator, as well as CMS and other regulatory agencies, collecting exactly what are the downstream outcomes associated with new drugs. And with that, I'll turn back to Jeff for recommendation 4.
Great, thank you. In many ways, building on the concepts that Dr. Walters has described around the opportunities of real-world evidence and the ability for real-world evidence to provide information on populations that may not have been included in some of the original clinical trials that were used to approve new products. We, as a group, thought that it would be important to recognize that while real-world evidence provides a growing opportunity to generate new sources of information and opportunities to learn over time, that clinical trials still remain the cornerstone of developing new and innovative therapies. But in order to recognize that clinical trials historically have had underrepresentation from various populations, whether that be racial minorities, health disparities, sex, age, all of which have had challenges in having active participation and inclusion into clinical trials, that it was important for us as a group to recommend that steps should continue to be taken in order to encourage the broad inclusion of within clinical trials. And this could include a wide variety of different initiatives, things like continued and enhanced education for physicians, identification of opportunities to participate for patients, increase of navigational services to help patients be aware of trials and work through the processes associated with participating in them. Looking at ways to expand eligibility criteria, for example, so that more patients are able to enroll in clinical trials where appropriate. Looking at increased reporting about subsets within clinical trials so that there's a better understanding of different subpopulations that have been included in trials more regularly, and ensuring coverage for routine costs in Medicare, which has been done in Medicaid, I'm sorry, which has been done in Medicare in order to ensure that that isn't a barrier for participation, and similar provisions could be passed in the Medicaid program to make sure that that also isn't a barrier for participation in clinical trials. And I'll pass it back to Ron.
Next. So taking up on that, and again, the ONC and DHHS has done a lot of work in this area. There is so much more to be done about standardized data elements. They are the key to the exchange of information. We've done a very good job with certainly demographic information, billing information subject to all the usual limitations is easier. But in the oncology world, and as a practicing oncologist, although I'm still able to sort through various technologies, usually PDF files, about date of diagnosis, the kinds of diagnoses that were deliberated, the one that was settled on, the final treatment plan in a importable fashion and in a standardized fashion, the results of that treatment, any subsequent developments in that disease, whether it be recurrence or being a survivor over time. Those kinds of data elements, which are very important to the clinicians in oncology, still involve a process that is predominantly abstraction and data entry and many times translation into the applicable system that you are using. So yes, access to that information has been dramatically increased, but the time it takes is still quite considerable, with many places that don't share the same EHR, with many places still having a cadre of mid-levels or patient access people who access the data elements and then literally enter them into your EHR. And we have to do a lot better job in that, in the true meaning of interoperability around the data elements that are very critical to cancer care. Go on to the next recommendation. And this has to be promoted, and reimbursement mechanisms have to support that interoperability and the aggregation of patient data. So that again is something that I would characterize is at its early starting points, but can be so much better, so that in the world of second opinions in oncology, again, you do not have to sort around data finding processes. The reimbursement mechanisms have proceeded along that line. Certainly, a lot of the physician reimbursement is supportive of that. But again, it's different. It's different from being supportive of it and then actually being able to do it with the patient data. That's important. And now shifting over again to the patient side of things, we have even much more work to do on patient data that supports shared decision making. And this is a key phrase that the group felt strongly about: increasing understanding between the patients, providers, and the payers. And you see the word shared decision making and implied the patient preferences in that paragraph. Everyone involved with that patient, including themselves, should understand the choices that have been made in the past, why they were made, and how much it was in sync with what the patient desired. And that is possible. We know it's possible. We have a lot of distance to go yet, and so we felt that continued policies and reimbursement really does need to support that level of interoperability and aggregation. Next slide. And the telehealth, which I've been around long enough to know that it's been kind of floundering. There's been pockets where it's been successful. But one of the things that the pandemic has done, and CMS has been extremely supportive about, is to enhance the usage and do so from a reimbursement perspective, to utilize telehealth so that potentially sick patients aren't brought into the same environment for many times services that could be done elsewhere and certainly outside of a sick environment. And that has been very much appreciated. I can tell you that I've been doing video visits for about 2 months now. It took us just a little while to get the technology right and in concordance with the law. But the patients really do appreciate it, especially if you've had a relatively long-standing relationship with that person. They realize that we're doing everything possible to protect them during these times, rather than trying to cause any more inconvenience. I've only had one patient. I realize that's a select group. I've only had one patient who just said technically that person couldn't do it. And of course, then we arranged a different way. But telehealth needs to, and there are signs that it is going to be continued to be supported, appropriate to the situation and appropriate to the services that need to be delivered. Tumor boards were specifically brought up because tumor boards are a mechanism that have been utilized for telehealth for quite a few years. They're one of the first derivatives of it. And that was very effective at getting providers around the table to share and discuss the pertinent facts to a given situation. It has worked very well over the years. And also that needs to be enhanced and continued and reimbursed accordingly. And when appropriate, even patients can be involved in those tumor boards. There's no question that some tumor boards literally did have the patient present, and they can be present virtually. So telehealth is one of the things that arose out of very unfortunate circumstances, but this movement is very strong and very definitely needs to continue. And the work group felt very strongly about that. So that is our policy recommendations, and we have a few minutes now that we have left aside for questions and answers, if you have any. If there's just too many of them, then we might change those to to later on if we have some time at the end.
Well, Ron, I think this is Cliff Goodman. I think we're okay with questions, and we've got a few for you, if you don't mind.
Good.
Sure. Cliff Goodman here to help moderate the questions here. Since it's supposed to be baseball season, I'm going to throw you, instead of a softball, a high, hard one inside. One of your more ambitious recommendations feeds off of what you mentioned about regenerative medicine being expedited, and that's great. And a lot of that had to do with clinical trials and FDA and so forth. But then, Jeff, you mentioned, what about extending it into the payment processes and looking at process modification? Now, one of the issues that I think we all see is that would require some close coordination between FDA and CMS. And both of those agencies are well steeped in their long-standing, decades-old legislation and regulations. And so maybe Jeff could start out with this one. And so, Jeff, what are the kind of expectations, realistically so, about FDA and CMS really getting together to make a more fluid process to get innovation from basically the bench into practice, as per what you're seeking in that recommendation?
Yeah, I think one of the goals of this was not to duplicate function. And so I think the idea that you've raised around having a closer coordination between the two different agencies is an important one. And if you look at how the agencies in oncology are even structured, you now have an FDA that has consolidated around a center of excellence that has over 100 expert medical oncologists that are reviewing these products from their very early days, understanding the clinical implications in order to make the decisions about the appropriate approval or additional information that would be required. To try and duplicate that at CMS would be very difficult, if not necessary. So are there ways to leverage that type of expertise at FDA in order to even, number one, increase communications, just to let them know what's coming, in order to be able to prepare those processes. So when a new therapy is coming that would require a new code, or perhaps even thinking further into the future that could require some sort of innovative payment process, as opposed to jamming that into a very consolidated point of time after the drug is on the cusp of being approved, when of course everyone is interested in trying to provide patient access. Can there be mechanisms that start that process sooner in order to take care of some of those administrative processes that need to be done on the current CMS cycle of things? And we thought that perhaps focusing around some of these innovative programs like RMAT or the Breakthrough Therapy designation could be a good start to explore, because while things like the Breakthrough Therapy designation are not equivalent to a guaranteed approval by any means, a lot of these products are quite successful. So it wouldn't be taking steps for CMS to implement processes for in most cases, a drug that would never get approved, which would be a resource deprivation if that were the case.
So anticipation and ramping up is important then.
Yes.
Yeah, and Cliff, this is Ron. I can only picture what I'm going to say and might be a little more ignorant than I think I am, but basically what you just described is what every business does as far as a strategic planning process. Who owns that process for every possible future development that could come along the way? How is that handled, and how is this interagency discussion that Jeff's kind of alluded to there from an IT perspective, from a billing coding perspective, from a payment perspective, from this, that, and the other remote approval, how is that coordinated at the current time, really, for any drug? And if you want to use CAR-T an example, pick on that one. It is really driven by the groups that do CAR-T. And yes, all those agencies are involved at some point in it, but where's that planning process for things like that?
Well then, Jeff, do you then therefore see a more fluid kind of business-like planning process and a smoother throughput?
I think it could be more regular. In some instances, I'm aware of times where the CMS review staff, as they're working through something, they may pick up the phone and call their colleagues at FDA. But for large part, even that point of contact isn't clear, or a process isn't set forth in order for that to be able to be utilized more regularly. And I think even in terms of some of the additional recommendations, there's opportunities there to do things like aligning on the post-market studies. And that comes back to real world evidence and things that could be coordinated even better across the life cycle of a product.
Got it. You just brought up real world data, real world evidence. Do you see that real world data would have the ability to be used both for the regulatory purposes and the payment purposes? Could there be some kind of consolidation and greater utility of real world data collected from EHRs and pragmatic trials and so forth to, again, make a more efficient process?
Ideally, yes, for a number of reasons. One, you could imagine that the information that CMS would like to have, or any other payer for that matter, I don't mean to just talk about public ones, would require longitudinal information about the long-term benefit of a product, particularly in instances of an unmet medical need or a life-threatening illness where there's the desire to expedite access to that, perhaps on some sort of intermediate endpoint, where real-world evidence may be able to help provide a role in confirming the benefit. The second area that was also alluded to in the group's recommendations was about the ability for real-world evidence to help generate information around patient populations that weren't included in some of those original trials. And in some cases, even though we are talking about oncology here, just where trials tend to skew, oftentimes may not provide sufficient amount of information around Medicare beneficiaries, for example, or different populations that may be covered by different payers, where they may want information about different subsets that may only be obtained through real world evidence, short of conducting another clinical trial.
Ah, good. Point well taken. That's a nice tie-in as well. A question that's come up through our system, it has to do with the adult and pediatric divide, and maybe Ron could take this one first, and that is, Ron, traditionally we've had difficulty insofar as whom to enroll in clinical trials and how do we handle the pediatric side as well as the adult side. And then of course there's that sector in the middle of kind of the teens and young adults. What is it about Cures that might help sort of close, or I should say better integrate across that gap? How do you feel about what it does for peds and teens? Particularly in cancer, of course.
Well, that was a 20-year question at our institution, and I think sometimes it's still, you have to give credit to the pediatricians of the world. Once they establish that relationship very early on, they feel responsible for darn well near everything that happens to them until they're about 70 years old. And so I admire that. And I don't think that is something that's going to be easily regulated, in my opinion, because situations change, and one 12-year-old may be a 17-year-old, one 20-year-old might be a 10-year-old. And you have to account for those situations. I think it kind of relates more importantly back to the handoffs we talked about. Picture the world instead where not only real world data, but also research data and clinical data that isn't research flowed smoothly with every person with a unique identifier through the system. So that there is no difference then between when you're 2 years old and when you're 20 years old and when you're 60 years old, because everybody can follow, everybody that needs to, everybody that's appropriate, can follow you during that period of time. And this whole classification of when are you a peds and when are you adult kind of fades into you're still a person, you've been a person your whole life. That IT can facilitate that. It really, really can. Does it do it this point well? No, it does not, because we have different systems, rules, and regulations set up for those different populations.
But Ron, does that not lose, are we still not going to lose the teens, that gap in the middle? The continuity that you're describing for data pickup, will that help ensure that clinical trials don't overlook that age bracket?
I think some of that drop off partly is cultural, partly is adolescent, but also is because they just plain get lost from a data perspective. The pediatricians say that over and over, that, well, gee, they're 13 now or 14, or they're under their parents' plan now until they're 25. We need to hand them off and tell the next person everything that's happened. Where's the person supposed to feel in that? If I were a person, I would feel like an abandoned person. Who's taking care of me now? I used to have a pediatrician, now I don't need a PCP yet. I don't think I do. But I think if, again, to echo what the work group, not specifically about this, but expressed in their recommendations, on the other hand, if I had a medical record of me and that was my information and then it was my response, I could carry that to the next person.
Okay.
And I'm more involved.
Okay, thanks. I'll take that from Ron as a good final comment, but back to you, Jeff. Jeff, in 30 seconds, looking across this whole set of policy recommendations, if you're going to kind of, lay your neck on the line for one that you just gotta have, and Cures Now or the next iteration of Cures has to do it, what's the one you'd emphasize if you had to push for one at the top of the list? What would it be, Jeff?
Well, let me take 10 seconds just to raise to the earlier point that we have been working with FDA and the task force with ASCO that has put forth recommendations a couple of years ago that FDA has now led to guidance documents about lowering the age for eligibility for participation in clinical trials to try and catch that group that you were just talking about.
Good point.
In terms of these recommendations, I really think this is a great opportunity where legislation can play a role in order to create more continuity across the process. So FDA has continued to excel. Cures provided the baseline funding to help instigate through the moonshot the discovery of new therapies, helped equip FDA in order to accelerate their regulation and development. And now we need to take it to the next step to think about how to leverage post-market evidence and continuity of processes in order to make sure there's not a gap between approval and ultimate access.
Excellent. That's a great wrap-up comment. I think that well captures the breadth of work that Jeff, you and Ron did with the group. Highly laudable, and especially in this time of public health transition and so forth. Not only do we have to pay very close attention to the points that you two just raised, but how those flow into and maybe even modified or enhanced given the conditions now and what Cures 2 might look like. So Jeff Allen, Ron Walters, and your great working group, thank you so much for this wonderful work. It's a great kind of stepping off point for the rest of our afternoon. Thanks, guys.
Thanks so much. And thanks.
Thank you.
All right, you got it. Back to Bob Carlson.
Hey, thank you, Cliff.